Choice is the glass half full, which is great. There's always a glass half empty, so why isn't it better? So, let's just step back for a minute. I think one thing that you kind of talked about a little bit, Debu, but I kind of want to push a little bit further, is in the various lines, these drugs appear to have a survival benefit. The combinations appear to have a survival benefit over individual endocrine therapy alone. So there's a survival benefit. I guess the issue is that a survival benefit has never been demonstrated to chemo in the setting as far as we know. Yet we're having the PFSs that are the same in Pearl. But will there be, small numbers, I know, will there be a survival benefit?
But it's a very different population of patients. And what I really have taken from this is that we should be giving the endocrine therapy with CDK4/6 inhibitor therapy early, because where we're going to see, and maybe that's what our problem with some of the endocrine agent therapy problems, even Bolero-2 were in the past, is that people had received prior chemo. So you're generating multiple resistance mechanisms. And first line, second line, Mona Lisa 7, the Mona Lisa and Monarch trials in the second line, we're seeing these really striking survival benefits. None of those patients received chemo in the metastatic setting.
I think that it makes sense to use endocrine therapy earlier for quality of life reasons, but I must say that with the patient heterogeneity, the fact that these patients are chosen for clinical trials, it's very difficult to say that sequence actually matters. We've hypothesized a lot based on models that it does, but I think we do have flexibility as to what order we might use things in.
So at this year's San Antonio, they presented data on real-world analysis, and I think this is where we're going to answer some of these questions if we believe in that. And the Flatiron database is now 2.2 million records. Say what you want about how accurate we think it is, but at this year's meeting, a real-world analysis was presented in the poster session of palbociclib and letrozole, and I think within the first line. And what they did is they looked at about 600 of each in the Flatiron database with about probably 3 or 4 years of follow-up. And they matched them, because what you have to do is do this propensity score matching to be sure that both cohorts are roughly the same as it could be. And they basically, in terms of PFS, replicated Paloma-2, replicated the first-line trial, and interestingly enough, actually had an OS benefit. So the interesting thing about this real-world data is, will that actually be borne out when Paloma-2, when the trials are come out? And if it does, then this may be an approach that we can use to kind of answer some of these questions, if we believe in that. Instead of because a lot of these questions will not be able to be answered by a randomized clinical trial.
But this question, this trial isn't addressing the survival benefit of a CDK inhibitor. It's asking a sequence question. Mm-hmm. I think the important point here is that the recommendations have always been to use hormonal therapy first, except in the cases of true visceral crisis. But if you look at what doctors are actually doing, at least in the United States, the most recent data was showing something like 60% of patients were still receiving chemotherapy as their first line of metastatic treatment for ER-positive disease. So I think the reassuring thing here is now this is just one more piece of data showing that hormonal therapy and first-line treatment works well. And there's really no reason to use chemotherapy as your first line.
That's a good way to take it. I agree with you. That's a very good way to take that.
Let me move on now to factors that may tell us a priori if patients may exhibit resistance to some of these newer targeted therapies like CDK4/6 in particular, and how we might be managing them more from a diagnostic point of view. Joyce, any insights that you would say we have a couple of trials that are looking at molecular testing, both blood-based and tissue-based, and informing decisions, and what we've learned from these studies?
Yeah, I think it was a very nice oral presentation from Nick Turner and his group on the kind of long-awaited plasmaMATCH, where about 1,000 women with metastatic breast cancer underwent ctDNA analysis, circulating tumor DNA analysis, by a couple of different methodologies. One is the commercially available Guardant technology, and the other is the digital droplet PCR. And the first good news was that there was very good concordance, between them. And secondly, looking at the ctDNA results vis-a-vis the metastatic tissues, also with NGS, there was also good concordance. So that was good, because I think there have been a lot of questions there about the reproducibility of these findings, but that was quite encouraging. Secondly, basically the blood found what we expected we would find on NGS, is the way I took it away. You know, these patients had some pre-treatment, so there were, you know, about 5% had HER2 mutations or so, 20-30% had PIK3CA mutations, there were AKT1 mutations, there were ESR1 mutations in a goodly number, et cetera. So it kind of recapitulated the NGS, which is also very helpful. And then patients were treated insofar as possible with agents such as neratinib for HER2 positive patients, alpelisib, everolimus, and patients benefited. Patients benefited about at the level we would expect. Also AKT inhibitor with capivasertib, those patients benefited very, very nice, which is great. So this is a very, very encouraging. First of all, I thought it was a good proof of concept, a large proof of concept trial, which honestly we really did need. Because we've been getting this in practice, we really needed a proof of concept, number one. Number two, when it comes to the issue you raised about resistance to CDK4/6 inhibitors, the list is growing. There's going to be people that are primary resistant. It's only about 20%, but there's going to be some, and we're going to need to know that up front. And we're going to need these rapid turnaround technologies that are reproducible and reliable for us so that we can actually, and then of course we'll be able to do it serially, you know, as well. And so very encouraging. So it was, you know, it was good. And we can see that would be helpful both with regard to resistance mechanisms as well as prospectively what do we treat the patient with next when she's progressing on a CDK, which is a big, huge question that we have.
So I'm not sure plasmaMATCH answered what a priori, what primary resistance looks like. I think plasmaMATCH answered what afterwards it looked like. It's kind of a continuation of what they did with PALOMA-3 a couple of years ago. You know, so and it kind of confirmed a lot of what they had. But I'm not sure we know. I mean, I know there was some stuff at San Antonio about maybe some interferon response signature or something like that, but do we really think we have anything by that now? You know,
Well, the one marker
who won't get it up front?
The one marker that I think has the most evidence but still needs to be validated prospectively is cyclin E overexpression. It's a
Right, I think
sort
that's a
of
reasonable
bypass
one.
pathway
Cyclin E is
through
a reasonable
CDK2.
one.
RB loss is pretty uncommon, and it does evolve over time, but not commonly. So I think you're right. The majority of the mechanisms, I think, still remain undefined.
Well, also in how to target those mechanisms, I think that we'll talk about a little bit more. I think it's really interesting to see this data presented and what can happen, but it's very heterogeneous. And, I mean, it's something like looking at resistance in triple negative disease, incredibly heterogeneous. And so it's hard to know. And, whether or not in the future we'll be able to use the same technology to figure out what's gone wrong and how to target that, maybe even in the earlier stage setting, I think is interesting. This rise of ctDNA testing is so incredibly important for our patients because a lot of people in ER-positive disease, really tough to get tumor, and you're biopsying bone, people are decalcifying it and missing all the receptors
within the organ too. We have that issue too. Allelic frequencies can be very low, and what is the clinical relevance of that? So we have a lot to learn yet.
But being able to do ctDNAs.
Apparently, I didn't realize, do you know how much fold they go, what sequencing depth they use actually in Garden? It's like over 100, 200,000.
Yeah, it's very deep.
Incredibly deep. They say they can pick up one molecule, apparently.
But does that
That's
help us
abnormal.
in the clinic?
That's a good question.
I don't know
In fact, if anything, it makes it worse.
Yeah, exactly.
Right, exactly.